Thank you, Matthias, for your speech. I hope it really was good for everyone here in our cell here. It's really revolutionary for the emergency medicine, I think. When I started to build up my slides, so I thought, what is the most important to speak here today in our emergency week or Akutveckan? And when we sat together with my colleague, we spoke about different aspects. One of them is the guidelines. The second one was the networking. And the third one, which is the most important one, which was the implementation, how we can implement critical care in our EDs. My name is Mohamed Abrougif, and I'm an emergency physician specialist working in Uppsala University Hospital. And I'm going to present how we can implement our critical care in the emergency. I like all my talks to be interactive, so I want you to share some ideas with me soon. In order to understand the future, so we need to go back to the history. And if you all know together, like how our ED was before, like for 30, 40 years ago, it was only a playground where other specialties, orthopedics, surgeons, internal medicine just come down to the ED, and when the patient comes, so the nurse just meet them, do a simple history taking, and then consult them. And this led to patient stays for many hours in the ED without even seeing a doctor. Till this man on the left side of the picture, I hope most of you know him. You can just raise up your hands if you know this person. Good. Well, actually, it's not really lucky, but he's one of the pioneers of the emergency medicine, Maurice Ellis. He's a casualty doctor, or he's a surgeon in background. He was, in the 70s, insisted, actually, that we need a permanent staff that works in the ED, that take care of our critically ill patients, or the acutely ill patients. And he was the pioneer, or the light that turned over us to build up our specialty. And here you see Tariq Hassan, one of the presidents of the Royal College of Emergency Physicians in England. He was visiting the blue plague that Leeds University made for Maurice Ellis. Then, many years after, so the American liked the concept that we need physicians that are permanent works in the ED and developing themselves to take care of the acutely ill patients. Many years after it, so the idea spreads to the whole world and to Europe. And if you see the evolvement of our emergency medicine specialty in Europe, you see on the right side here of the picture is the Eastern Europe, and on the left side is the Western Europe. What got my attention is, if you see the Eastern Europe, so the development of the ED, or the emergency medicine, have established much way earlier before. Like in Bulgaria in 1996, in comparison with the Scandinavian countries like Norway 2017 and Denmark 2018. So I just want you now to speak with someone that sits beside you and give me some idea. Why do you think so? Why the emergency medicine evolved in Eastern Europe much way earlier before in comparison to the Western Europe? I give you 2 minutes just to speak, and then I want just voluntary answers. Yes. Yes. Because we don't have too much time now, so I will make it a little bit less than 2 minutes, because it will be an interactive session. I want a volunteer from this group to tell me why. There is no wrong or right, just answer, or yeah, you can just throw.
I have a guess. The hierarchies. Senior surgeons, specialties, specialists from intensive care. Okay, I'm done. I want to work up in my ward, the surgical ward. I'm not going to put foot in the emergency again, which led to colleagues in the beginning of their training working in the emergency, causing injuries and death to patients, before realizing we need someone that's a specialist down here all the time.
Thank you. Volunteer from this group. Oh, you just can't throw it.
Oh, random. Okay, let's go.
Oh. Rasmus, don't cheat.
I'll see you.
As I said, there is no right or wrong.
Okay, I'm trying. So, my chief colleague at Södersjukhuset, South General Hospital, actually comes from Romania. So, he told me that in Eastern Europe they were underdeveloped, so to say, in their EDs. So, they actually just after I think the Berlin, in the late 80s. They just, began from the scratch, I think. Yeah.
I really like your answer, because what I think personally is the same. Till now, thanks God, so we have a very well-established healthcare system in Europe, Western Europe, and in Scandinavian countries. You have till now very good primary healthcare, we have very good elderly care, and also we have a very good hospital specialty care in comparison with Eastern Europe. That's because of the geopolitical crisis, the economic crisis, and the wars. And this will lead to all the healthcare system just crashed down. And they want some people to take care of the emergency department. And it became too late, and this put pressure on all colleagues in the Eastern Europe in comparison to us. So, I traveled with my colleague last year to attend ISEM. I know maybe some of you were there. So I was very, very interested just to see, because I see many articles from the Canadian colleagues, from New Zealand and from Australia. And I just know why we think they're better than us, why they are doing more things than us. So I passed by Toronto Hospital to Sunnybrook and to meet them and see. Sunnybrook is one of the major trauma hospitals in the world. They see every 3 hours or 4 hours, like a trauma 1 alarm. And when I asked my colleagues, so how did they do this? They told me, because of the healthcare system there is crashing down, and this put the pressure on the emergency physicians to survive, just to take care of themselves. So if they got patient with retrobulbar bleeding or the increase in the pressure or something, the lateral catherectomy, no ophthalmologist will come to the ED. They ask you to do it and send the patient back to us. Surgeons operating in the operating theaters for many hours. You have patients with a trauma, hypovolemic shock. They are forced to do Reboa to survive. So, till now, thanks God. But, if you see what we are facing nowadays, we have the geopolitical war, the economic crisis. We don't know our future, our healthcare. Maybe it's going to be better, or it's maybe crashed down. So that's why it's very important early now to save ourselves and to make an identity of what is the real emergency medicine is. And we need to follow the European guidelines as well as the other world guidelines. So now also, I will share the questions to you. I usually read and very positive, and I'm present in social media a lot and see a lot of comments about critically ill patients. And I want you now to speak with each other if you give me a definition of what is a critically ill patient. So you have now only 2 minutes. You can use these questions as a help guide for you. And then also I want volunteers. Yes, time is finished. I want a volunteer from this side. You can throw the ball or the box. Where was the ball? Just throw it. Yes.
Basically all of the above. But if you want to say something clever to that, either patients who have the cascade physiology is triggered, and you will see that even if the patient is stable now, there is a risk of imminent deterioration. Or you have the more constant slope of getting worse with more stable physiologies like injuries that doesn't trigger the cascade systems, etc. And then I think Scott Weingart put it nicely, if you've seen the Scott Weingart index. Yeah, looks like shit, yes or no.
Exactly. Thank you, Christina. Just throw it to the other side.
Yeah, I was going to say kind of the same thing as our colleague there. I think in addition to that, maybe what is critically ill might be defined as well depending on which system you're in and how fast it can be worked up. So in certain systems, something that would be critical, I worked in both Denmark and in Sweden, and what is critical in Stockholm is different than what is critical in Denmark sometimes, depending on how fast you can get a workup done and how fast you can get a follow-up done. Yeah.
Thank you so much. And that's what our problem is, and that's why I just want to ask to know, because we all, when we sit here, we have a different picture of what a critically ill patient is. For me, I cannot give you also a right answer or wrong, because it's a very difficult spectrum. It's a spectrum of illness with a varieties of process. Give you, for example, a sepsis patient. It's not only a bacteremia in the blood, there's many systems and organs that get involved, from the respiratory, from the cardiac, and from the urinary tract and other else. So it's very difficult. And I thought I give you a lesson or a homework when you go home, just build up like an idea what is a critically ill patient looks like. And then the other question for you all, where do you think the critical care begins? Does it begin in the ICU unit only? Does it begin in the ED, or it begins pre-hospitally? 1 minute, and then we move. Yes, time's out. There, you have the box there. Yes. You can just throw it to someone here. Yeah. Oh.
We argue that it starts right away, depending on what you have available to you at the moment.
Thank you.
No, I don't want to.
There's no right or wrong.
Yeah, we argue that it starts pre-hospitally. Yeah.
Exactly. I totally agree. But the problem was too many years before, so they thought like the critical care only starts in the ICU. And what you do pre-hospitally and in the ED is just a supportive treatment. You just fill the patient with fluid to compensate for the cardiovascular collapse, to give the antibiotics, give the paracetamol and everything, just to let the patient survive till you see a better doctor. Not a better, sorry to say this, but to see a more a resuscitator that is really more capable of those things. But years after years, you see now, I said the crisis that is coming, we don't have too many ICU beds in our ICU units, and this forces you to keep those patients in your ED for many hours, to stabilize them in order to send them to a normal ward or to send them to the ICU when there is a place there. And if you see, many years after come some of the articles. I'm not going to go in details with them. Here are some. One of them about the sepsis, which is recently has been published. What we are usually used to do is keep those sepsis patients, we think that they are unstable. And when we contact our colleagues from the intensive care, they thought the patient are stable. And they ask us and for us to give fluid, even though they have a heart failure or not, just to compensate. And this will lead to bad results. And these studies shows that early ICU treatments for the critically ill patient can lead to better outcomes. So maybe all of you think, but why we are doing this? If we think about the patient perspective, those patients who comes to the ED, they have very, very, very little reserve left. Either they crashed at home, that's why they called the ambulance, or in the ambulance, in the transport, or in the ED. And as we said, the time is very critical in those patients. And any mismanagement of those patients will lead to a very severe consequences and bad outcomes. If we speak about the variation, go back to what Matthias said before. We have been seeing when we established our critical care committee in Sweden, we are doing actually some part of critical care. But what we saw, like in the southern of Sweden, they do some type of critical care. In the middle of Sweden, they also do the same. In the northern, maybe do something different. But we don't have something homogeneous between us. We don't speak with each other. We don't share publications, studies, guidelines, and experience. So that's why it stayed very, very weak. And you see some of the colleagues, when the critically ill patient just arrived to the ED, they just go and press on the button for a critically ill patient or something in order to get more help from other colleagues. Some of our specialists, they do some type of critical care, and when the patient crashed down, they call. So it's very different in the experiences and the knowledge. How about Sweden then? If we see now, we are very increasing specialty. We have many, many specialists now. We are taking care of all the patients come to the ED, regardless if you are working in a big hospital or you are working in a small hospital. You are taking care of all the patients that come, 24/7 a week. But till now, we have a competence gap in the management of critically ill patients. And that's the problem, that when those patients come, we don't have anyone who is really responsible for them. By the end of the day, it will be your name because you will admit those patients. But in reality, you don't have any responsibility for them. So now also I give you 1 minute. I want you really to explain for me, how do the critically ill patients in the ED differ from the critically ill patient in the ICU? I'll give you 1 minute to speak with each other. Yes, time is out. I want one answer from there. Where's the box?
Vad ska vi säga? In the ED, we don't always know what the problem is. You just need to act.
Thank you. Can throw it to the other side.
Hi. From a Finnish perspective, I think in the ICU, they receive a quite well-packaged patient that they know what the patient, what the problem is. The treatments have started and so on, and in the ED we get a patient that comes in like in a more, what should I call it, in a more premature state of the illness. Yeah.
So actually the critical care is the easy part. The hard part is to recognize the patient and treat him or her early enough. So they are doing the easy part of critical care. And I know it since I have done that too.
Exactly. Thank you so much. And to be honest, if you just look at those pictures, what do you see? I think you all can resuscitate a patient by the end of the day, but the problem is logistics there. If you see the picture down, ICU, they're wonderful. They are elite in resuscitating a patient because they are trained in teams and they have a quiet environment, right? So what they are mostly focusing there is only to prevent the complication and continue with the supportive resuscitative treatment. And most of the diagnosis, as you said, is well known. But in comparison with us, if you see now, and those in the picture above, you have 2 trauma at the same time. And you see, it mixed with a lot of people, a variety of specialties. If we translate this picture to Sweden today, so this man here, he will be like the trauma leader, most of the time will be surgeon. There in the up, you have the anesthesiologist, and then you have maybe the emergency physician there, and you have the nurse, the ICU nurse, and you have the emergency nurse. Think like those people have never trained with each other in any critically ill patient, and one day, 1 second, they need to come down to resuscitate a critically ill patient. It will not be so good. And this will lead to what? The surgeon has his opinion and suggestions, the anesthesiologist has his opinion and suggestion because they're focused on their areas. This will lead to the ICU physicians, where because they are elite team, they are trained in resuscitation in a controlled environment, they come down and take over. So and why? Because they are trained together, they trust each other, they work together with each other in resuscitation, and this is what we need to do. Practical consequences, and nowadays that we face in Sweden and most part of Europe, like this. It's a rubbish, you don't see anything. And why is that? Because if you work in your ED, you see a lot of machines, a lot of equipment, a lot of medications that's present in your resus room. This is for the surgeon for thoracotomy or the thorax. This for the anesthesiologist, this for the ENT. And you don't really own your emergency department because it's really fragmented into different types of specialties. And this will lead to also to other problems. It's not on our side. It's also when we consult other colleagues. When the ICU comes down, they don't know even where the stuff is, they don't know what we have, and they come with their routine, what they are trained about. So that's why you see like they push you away because they want to take care of that patient. And that's good because they don't see any help from our side. And what's happened also is, if you have this picture before, 2 trauma at the same time, and if we get near all the specialties, this means we lock down the hospital in at least 2 hours. Because there's no any surgical theater, the grand wards is totally empty with no physicians because everyone is here down. And this will lengthen the stay of the patient that already admitted to the hospital, day after day after day. So, what me and my colleagues think, how can we improve our critical care in the ED? It depends on the resuscitation philosophy. And the most important one is own the emergency department. The other one is the individual. As a person, I should have a responsibility. The third one, team responsibility, organizational responsibility, and mastery through repetition. First, own your ED. We have been hearing a lot, like, yes, well, we are a new specialty in the world now, and just give it a time in order to build a very good society, then we think about critical care. Other groups says, no, we usually cannot do anything because the hospital will not even allow us. The anesthesiologist will never allow us to do things. The cardiologist will never allow us to do things. The orthopedics and etc. And the problem is, when we speak like this or when we think like this, we think only and see the tip of the iceberg. We don't see the bottom of the iceberg, which is much huge, which is us. Me, myself, when I started the specialty, and my colleagues, we all the time put the blame on the tip of the iceberg, on our colleagues from other specialties, but we never thought about ourselves. So we need to think like, from today, I need to trust myself, I need to own my ED, and trust my colleagues who are working with me. You need to be the Lion King of your jungle. The individual responsibility. I think the best way is what I like from Scott Weingart, what he say, you need to own your ED and you know everything that is present in your ED. So from tomorrow, I hope that when you go to your ED, scan all the rooms that you have, scan all the equipment that you have, scan all the machines that you have, and know why we're having them and how to use them. Because one time or once a day somewhere, you will need them. Team responsibility, which is very important. I think we should, when we work with our patient, build up a team that is made of emergency physician, emergency nurse, and emergency staff. And this team not need only to take care of the patient, but need to communicate with each other, need to build up a trust in resuscitation, which means that today I'm doing a task shifting with my nurse. Okay, today you're gonna take care of the airways. The other day, you're going to take off the IV lines, and we task shift between each other. If we don't have any patient, maybe it's better to do in situ simulation and train with each other and waiting for something that is not really happen. Organization responsibility. I think you should put a pressure on your organization for the ED. The organization must have a clarified picture of what is the real emergency medicine is. They need to put local protocols, local guidelines for the resuscitation. Also, what we usually do is, in the first time, you do like a CPR training and then you receive a certificate, and 5 years you never do it. This is really wrong. You need to practice every day in order to improve your skills. Master through repetition. What I like, we have a colleague from Canada, one of them is Andrew Petrosoniak, and when he do his in situ simulations, so he thinks like this. When he start the session of simulation, he gave them a case and he gave them an answer. All this, by the sudden, everyone got shocked, but why you give us like the answer of the case? Yeah, because he doesn't really care about the answer. We care about the logistics. So it's very easy in our training and sessions that when we simulate and train, we do, yeah, okay, I will put the IV line. I will put the blood pressure set. I will put the ECG electrodes, but it really takes time. So that's why when you train, do it in reality to improve your skills. And one of our colleagues from the US, all know him, Scott Weingart, he said about the resuscitation philosophy. He said like this, slow is smooth is fast. And what he means by this, he usually gets all the time eating lunch with his wife, and when he drive home like to work, he drive like crazy. It takes for him about 10 minutes to arrive, while his wife, she drives very slowly. And she maybe reached home 1 minute or 2 minutes late, but she reached home. But when he drives so fast, there is risk that he do mistakes, he crossed the yellow light, the red light, and when he crosses them, he will be locked down. And what I mean by this is we need, as individuals, train and train and train. We not need to put the blame on others. So you need to take this responsibility. Tomorrow I'll go to my resus room, I train about every equipment we have. I ask my nurse, I speak with my ICU colleagues how to use the ventilator, the RESP, the infusion sets, and everything. What we did together with our colleague, we are building up a SWISM Critical Care Committee, and we hope like in the near future, we'll be responsible for the guidelines, for the implementation of critical care, and with networking with other specialties. So I hope we will reach that in the future, Frida. Right? Yes. Now, if we change this to you, how can you improve the resuscitation in your ED without depending on other specialties? I'll give you 1 minute before we finish, and then we speak. But
Om du bara säger att vi kör bara en kort.
hello. Yeah, time is finished. Now, just a quick answers from that group. Where's the box? Just volunteers. Yeah, you can just throw it.
I think we need in situ simulations and practical procedure skills training together with our nurses, the specialist nurses in emergency care, in real life, and actually do what we say and we should do as specialists in emergency medicine.
That's totally right. I totally agree. Yes, move the box. Oh.
Yeah, I also think that it's very important to get the rest of the staff in the ED with us on the train. Because if we don't have the nurses with us, I don't think it's possible.
Exactly. And that's what we together from the committee, we're starting to establish a good work together with our emergency nurses to build up a very, very, very strong team. Thank you so much, everyone, for joining my session. I will give you only 1 minute a break just to walk around here, and then we will have a panel talk. Okay?